Thank you very much. I appreciate everyone, and I'm honored to be here as a guest speaker. So again, my name is Dr. Andrew Kim. I'm a board-certified psychiatrist. I was also a principal investigator, which is the title for a physician who is deemed as the lead physician in a clinical research study or clinical trial. And tonight we're here on behalf of our sponsor, or my sponsor, Janssen Pharmaceuticals, to talk about Spravato. Spravato is intranasal esketamine. So many of you here may have already heard or seen in the community currently with ketamine being used to treat difficult to treat or treatment-resistant depression. This is actually the enantiomer of ketamine called esketamine. And this is the first true novel NMDA receptor antagonist that has been approved to treat major depressive disorder, specifically for treatment-resistant depression in adults. So today we're here to talk about Spravato or intranasal esketamine and its usage in treating major depressive disorder in two challenging to treat populations. Next slide, please. Next slide. Thank you. So some program disclosures. This promotional educational activity is brought to you by Janssen Pharmaceuticals. It is not certified for CMEs. I am a paid speaker on the Janssen Speakers Bureau, and everything I need to talk about today will be on label, so I can't talk about anything off label or answer any questions that are off label. Now typically this is a 60 or 70 minute presentation. I was asked to condense this to 20 minutes, so I'm going to try my best to not talk too fast, but present relevant material. It sounds like we have many primary care physicians, internists, family medicine, where this may be somewhat relevant for the patients you see in your clinics as well. Next slide, please. So as a brief overview, we're going to talk about the use of Spravato, or intranasal esketamine, in treatment-resistant depression. And that's defined as adult patients with major depressive disorder who have had inadequate responses to at least two or more oral antidepressants. And also briefly, we'll talk about the use of Spravato in adults with major depressive disorder with acute suicidal ideation or behavior. So a very high-risk population. And this type of population is typically excluded from clinical research due to the acuity and the risk involved. But this was a population that was actually studied by Janssen. Next slide, please. So we already talked about the indications. Listed on the slide are some limitations of use, which I'm not going to read for the sake of time. Next slide, please. These are some of the boxed warnings that you will find on Spravato. Warnings of sedation, dissociation, the potential risk of abuse and misuse, and a very familiar black box warning that you will find on most antidepressant class medications. That's the potential risk of increased suicidal thoughts and behaviors in pediatric and young adult populations. Next slide, please. And next slide again. So just as a brief primer, for those of you who are not as familiar with the prevalence statistics of major depressive disorder, or what we call clinical depression, currently as we speak, about 21 million US adults age 18 and over, at least in 2020, we're going through a major depressive episode, 21 million adults. And that prevalence is only increasing as we've gone through the pandemic and as we continue currently in our current state of our country. So this is a relevant topic. It's an area of unmet need. And for those of you who are in primary care, you are at the forefront of already treating the vast majority of these patients. And I'm certain that many of you, just as I, will get frustrated as we try to approach treating our patients with our standard treatment algorithms, with our SSRIs, SNRIs, and finding a subset of patients that are truly challenging to treat. Next slide, please. Back in 2006, the STAR-D trial had their results published. This was an NIH-led initiative where they wanted to study adults who had clinical depression, or MDD, and study with each sequential treatment with a monotherapy SSRI, citalopram, fluoxetine, sertraline, etc., to see what would happen with sequential treatment. And to summarize this quickly, By the time a patient did not respond to 2 treatments, and by the time they reached that third arm, the rates of remission went down to 14%. So very challenging. So about 1/3 of patients with MDD would meet the criteria for treatment-resistant depression. Next slide. The other thing that's not talked about from the STAR-D data is that for those patients who made it to that third arm who were deemed to be treatment-resistant, the rates of relapse, so even after achieving remission and doing well, their rates of relapse were very sobering. About close to 2/3 would relapse into a new episode of depression within the first calendar year. And the time it took to relapse is only about 3.1 months. This demonstrates not only the challenge to help someone recover from depression, but to maintain them in remission, which will be relevant later. Next slide, please. So we're going to be looking at the clinical trial data that led to the FDA approval of Spravato. And again, I was actually a principal investigator that was involved in these trials, so I'm not just a gentleman who's just reading off bullet points, but was actually involved in recruiting patients and volunteers to be in these studies, collecting the data and witnessing firsthand what was occurring. So hopefully I can lend some clinical pearls of wisdom here. Next slide, please. So to be very brief, this slide in itself could be a 15-minute slide, but basically, the patients that were recruited into these phase 3 clinical trials that led to the approval of Spravato, we were looking for adults who met the criteria for clinical depression or MDD that did not respond to at least 2 adequate trials of antidepressants. Now, what this slide does not demonstrate is that they were allowed to fail up to 5 antidepressant trials in the 2 years leading to consent. Once we knew that they met this criteria for treatment-resistant depression, patients were divided into 2 groups. To be clear, there was not a group that went untreated due to the high-risk nature of the study. Every group received a new antidepressant. So one of 4 choices between 2 SSRIs and 2 SNRIs. So everyone received a new antidepressant. Now the difference was, between the 2 groups, one group would also get Spravato or intranasal esketamine. The other group would receive a placebo nasal spray. And the primary endpoint, what we really wanted to know, was that at the 4-week mark, was there going to be a difference in the severity of their depression? And that was the primary endpoint. Next slide, please. And obviously we wouldn't be here today with an FDA approval if there was not separation. So at the 4-week mark, there was a clinically significant superior improvement in the group that took Spravato nasal spray along with the antidepressant versus the group that received the placebo nasal spray and the antidepressant. So bottom line, there was a clinically significant difference in those 2 groups. Next slide, please. And next slide, please. Thank you. Now, back to the earlier slide, where I mentioned the sobering data and the challenge of, that's great, you got your patient to improve in the short term. But what about after that? As we saw the sobering data about almost 2/3 of treatment-resistant patients then relapsing and sliding back into a brand new episode of depression. So we also wanted to study, does maintenance treatment make sense? Those patients who did well in the short term, if you provided them with maintenance treatment, would this actually delay the time to onset of a relapse and reduce the risk of relapse? So what we did was called a long-term maintenance of effect study, where in the first part of this study, everyone who participated for the first 16 weeks, we knew they were getting Spravato. There was no mystery and no placebo group. Everyone received an antidepressant and Spravato nasal spray. They received this for 16 weeks so that we can identify remitters. Because obviously you can't study relapse risk unless you identify a group that is doing very well. So the whole point of part 1 was we wanted to identify remitters. If you can click next for me, please. Thank you. And one more time, please. Thank you. So once those patients who were doing well or went into remission were identified, they were then randomized into two groups because this is when the actual study began. One group, nothing would change. They would continue on maintenance treatment. The other group, we would swap out their Spravato nasal spray for the placebo spray, but they would continue on their oral antidepressant. So to keep this simple, once you got better in the short term, did maintenance treatments make a difference? So if we move on to the next slide, and one more, next slide, please, thank you. So if there's one slide that I would want you to remember from this presentation, it's this slide right here. The red line is the group that continued on maintenance treatment with Spravato and the oral antidepressant. The gold line is the group that did not continue on maintenance treatment. The maintenance treatment group with Spravato was 51% less likely to relapse. And that is a big achievement and an important takeaway, given how challenging it is to maintain remission in clinical depression. Next slide, and next slide. Thank you. And another key takeaway here is, as I've participated in over 100 clinical trials, I can say that this is one of the first that I was actually excited to speak about, because this is not a copycat drug. This is not a me-too drug. And for those of you who are in the audience who are in family medicine, in internal medicine, you know by now there are about 18, 20 different variations of SSRIs, SNRIs, and people get tired of having just random variations of the same thing. This is a novel mechanism of action that involves affecting the NMDA receptor. This is an NMDA receptor antagonist that affects glutamate transmission. And this is kind of where the field of psychiatry is going when we're researching how to treat depression at this point. Next slide, and if you can click next one more time, please. Thank you. So, for those of you who are not as familiar with glutamate transmission, we believe that glutamate abnormalities are identified in the brains of individuals with clinical depression. Now, when you antagonize NMDA receptors, this eventually leads to an increase in the activation of something called BDNF, brain-derived neurotrophic factor. And we believe that activating BDNF leads to increased neurogenesis and synaptic excitability and plasticity, and we believe that this theory is now a new part of the theory of how we conceptualize treating clinical depression. Next slide, please. Bottom line, in the short-term trials, Spravato plus an antidepressant showed clinical superiority versus the group that received the placebo nasal spray and the oral antidepressant. And in the maintenance of effect trial, the group that continued on maintenance treatment with Spravato was 51% less likely to relapse. Those are the key takeaways. Next slide. Next slide. Next slide. Next slide. Thank you. So now let's go over some safety data to make sure that we are presenting a fair and balanced presentation. There are a few contraindications to Spravato: aneurysmal vascular disease or AV malformation, a history of intracerebral hemorrhage, and obviously an allergy or hypersensitivity. Part of the reason some of these are here is because there is the potential risk of raising blood pressure. And the peak of that typically occurs about 40 minutes after the administration of Spravato. Next slide, please. These were some of the high-frequency adverse effects, and some of these contributed to the need for 2 hours of post-dose monitoring. So again, that is one of the issues with Spravato administration, is that after each treatment, you need about 2 hours of post-dose monitoring at a certified facility that has been trained to administer this. So sedation occurred in about 48 to 61% of patients, and for the vast majority of patients, this resolved within the first 2 hours. Next slide, please. Dissociation occurred in 61 to 84% of patients, but again, the vast majority had this resolved within the first 2 hours of post-dose monitoring, so a time-limited, self-resolving adverse effect. Next slide, please. Given the potential risk of abuse and misuse, we just ask that you do a very careful screening history prior to referring someone for Spravato treatment. Next slide. And again, bottom line, this will not be taken by patients at home. They cannot pick this up at their retail pharmacies. This will only be administered at trained facilities that are REMS certified, Risk Evaluation and Mitigation Strategy REMS. So patients can only receive this at certified facilities. They will not be taking this at home. Next slide, please. We already went over this morning. Next slide. And again, to be mindful of increased blood pressure as a potential risk that typically peaks at the 40-minute mark. This will be observed by the clinical staff at a treatment center. The peak tends to happen at the 40-minute mark. And again, patients who were recruited into the clinical trials were not excluded simply if they had hypertension, only if they had hypertension that was not well controlled. So if they had hypertension that was controlled, they were allowed into the trial. Next slide, please. And one more, next slide. Thank you. All right. And next slide. Oh, sure. Next slide. Next slide. Next slide. Next slide. Next slide. Thank you. So I will be very brief here. We also have another FDA indication for the use in adults with major depressive disorder with suicidal ideation and behavior. So to be clear, this is the type of population that is typically excluded from clinical trials. We decided to study a very high-risk population, adults who had clinical depression with suicidal ideation and intent. So patients had to express they actually intended to act on their suicidal thoughts within the 48 hours of consenting for the clinical trials. To be brief, once we felt that they met criteria, both groups would receive an antidepressant or standard of care treatment on the inpatient facility. But one group would also receive Spravato, the other group would receive the placebo nasal spray. The primary endpoint for this study was actually 24 hours later. So one day after the administration of the first dose of the nasal spray. Next slide, please. And to be very simple here, the group that received standard of care treatment and intranasal Spravato, they had clinically significant superior improvement at the 24-hour mark versus the group that received the placebo nasal spray and oral antidepressant. Next slide. Next slide. So key takeaways to end our presentation is that for this FDA indication, we studied a high-risk population that is typically excluded from clinical trials. Patients with depression, suicidal ideation, and suicidal intent. And at the 24-hour mark, the group that received standard of care inpatient treatment while also getting the Spravato nasal spray showed clinically significant improvement compared to the group getting the placebo nasal spray, but we still recommend at least 4 weeks of treatment. Next slide. Next slide. This is a dosing algorithm. So the difference is for the group receiving treatment for treatment-resistant depression, you do twice-a-week dosing for 4 weeks. Starting dose of 56 milligrams. Subsequent doses can be flexibly dosed at 56 or 84 milligrams. Then once a week treatment for a month, and then once a week or once every other week for maintenance. In the depression group with suicidal ideation intent, we start at the higher dose at 84 milligrams twice a week for 4 weeks. Next slide. Next slide. Next slide. These are the rates of discontinuation, 4.6% in the short-term study, 2.6% in the long-term, and 6.2% in the suicidal ideation study. Next slide, next slide, next slide, next slide, next slide. Thank you. So in summary, we proved efficacy in the short-term trials, maintenance of effect studies, and in studies studying clinical depression with suicidal ideation and intent. I thank you for your time. I tried to make this as brief as possible, and I'll give it back to our host. Thank you very much for your time.
Thank you so much, Dr. Kim. Really appreciate it. This was a 60-minute presentation that he condensed to 20 minutes. So I think you should give some kudos to me too, because I wanted to make sure that. Thank you so much. But thank you so much for we are progressing towards some more shorter talks. I know that we teach for 45 minutes, but we have shorter spans, right? Attention spans. So next up is